One of the things we talked about this morning is this whole sort of dichotomy really of transplant eligible, transplant non-eligible. What do we actually mean? It came from an era when we didn't have as much understanding about aging biology. It came from an era when we didn't actually have the breadth of biological agents we have now. So maybe one of the things we need to do is revisit what we actually mean by transplant eligible, ineligible. A lot of the times it's a decision that's made by a clinician, usually without engagement with the patient about whether they think they are eligible for dose intensification. And the reason why I say that is because when you look at transplant-ineligible patients, we have people we deem to be fit, there's people we deem to be unfit, and then we have people who deem to be frail. And one of the things about these scoring systems is that at the outset don't differentiate with the disease overlay as much as the comorbidities. So people's performance can improve after they have several rounds of anti-myeloma therapy. So it needs to be thought in a more dynamic way rather than an instant decision that's made in a clinic, which tends to be the way it is. So there are people who are fit but not fit for a transplant. Well, what do we really mean? Are those kind of people who might benefit from VRD light and then a dose modified stem cell transplant, as opposed to not being considered at all for dose escalation. There are trials where, in the planning, where they are looking at trying to intensify the approaches for those patients. The intermediate group, the unfit group, they're somebody who may actually also improve their performance into the fit range, so you might undersell them in terms of treatment strengths going forward. And then the frail population. And one of the things we're starting to realize is that the frail population are, again, a heterogeneous group. Within that, there is probably an ultra frail group who, no matter what you try and do, are not going to manage particularly a 3-drug regimen, definitely not a 4-drug regimen. But some of the non-ultra frail patients may actually be able to uplift, when you control disease, uplift into a better category. The point of all this is that maybe what we need to be doing is delivering treatment to control the disease after a few cycles, reevaluating a person's fitness, and then make a decision about how we consolidate, how we maintain that response. But there's still a lot of work needs to be done. We don't really know the dynamic nature of these clinical scoring systems, and therefore there is also a new avenue opening up for us to be developing biomarkers, laboratory or imaging biomarkers that might help to delineate these patients, the good from the bad and the rescuable from the non-rescuable going forward.